Okay, so again, last time we talked, it was all hand and wrist. We focused on all those specific positions. By the way, those are not the chapters that you'll find these body parts in. Of course, all the way up to the humerus is going to be in chapter 4, of course, or elbow at least is going to be in chapter 4. These are an older set of notes that I'm using. Still, nothing's changed. We all still have the same bones from a couple of years ago, right? So the notes are still good. So the theme, right? Let's just kind of backtrack a little bit to hand and wrist. You know, the theme with the hand and wrist was there are a lot of bones. They're small, right? There's many, because there's many of them, and they are small, we have many articulations, many joints, right? So the theme of hand and wrist is having many, many, many joints. The theme for like forearm and elbow, it's all long bone, right? Forearm's long bones, yeah. The elbow's made of joints created by those long bones. We have fewer joints, but we're going to need to learn to recognize more radiographic anatomy. So not like individual bones, but individual points on each bone. That's the idea here, is we're going to try to be able to recognize radiographic anatomy, not by individual bones. We should be able to do that because there's only a couple bones, but it's going to be recognizing the actual landmarks, the bony landmarks on the bones. So that's what we're going to be working with today. So let's go ahead and do that. Let's start with our forearm. And you'll see the same thing happen in the leg, right? We have a hand and wrist with many bones. We have a forearm with fewer bones and an upper arm with even fewer bones, right? Many bones, 2, then 1. Yeah, you see that down on the lower extremity too, right? The feet and ankle have many bones. The lower leg, tibia, fibula, 2 bones. And then the thigh has 1 bone, right? Many, 2, then 1. So a decrease in the number of bones as we move proximally. As we move proximal, again, is to move toward the midline of the body. So that's the theme as we come closer. Less bones, less joints, less articulations, but these articulations just as important, right? Your elbow joint just as important as all of those joints in your wrist, right? Different movements, different things, but still just as important. Here are our forearm bones, the bones of our forearm, the radius and the ulna. These are classified, remember our classifications for bones, right? Long, short, flat, and irregular. These are long bones. We said long bones, one way to classify a bone as a long bone is just any bone that's longer than it is wide, right? And these, of course, qualify for that. They're longer than they are wide. These bones, of course, radius and ulna, form the articulation at the wrist. They articulate with the carpal bones at the wrist, distally, that's at the end of the bone, and they articulate with the humerus, the upper arm bone, at our elbow. You'll also notice that down at the wrist, one of these bones is more or less fixed to the wrist, where the other can kind of rotate, but up at the elbow, the opposite is true. So for example, down at the wrist, the radius forms the largest articulation with the carpal bones. The ulna, it has the small, you'll notice like physically they're smaller, right? The radius is large down here, the ulna is small. Those roles switch proximally. Okay, proximally at the elbow, the ulna forms the majority of the elbow joint, where the radius is much smaller, has a completely different role. Oh, thank you. I got yeah, actually, that's good. Thank you. Appreciate it.
That's what you want.
Yeah, I got a staple one, but thank you. Appreciate it. Okay. So now that we have our 2 long bones of the forearm, let's start labeling the anatomy on them. And yeah, you know, with the hand and wrist, there were, you know, what do we count? 12 and 2 is 14, plus all these metacarpals, plus all these carpal bones, right? We counted many bones of the hand and wrist. There's 2, right? So you think maybe easier, yeah? But then you look at the actual images that we're going to be looking at, and, you know, there's a lot of anatomy going on there, right? So we need to learn to recognize this radiographic anatomy, and it starts with looking at like the drawings of the bones first. So let's go ahead and just start the way I like to start, which is distal, down at the wrist, and let's review what's going on down there. And you'll notice, right, let me zoom out again, sorry. You'll notice that most of the fun is happening up at the proximal end at a joint, right? And then down at the distal end, also at a joint. Yeah, not much is happening right in the middle. Okay, because the middle is just the length of the bone, or the shaft of the bone, or the diaphysis if we're using a more technical term, right? But the length of the bone is just the length of the bone. So all the fun stuff's happening at the ends. Let's go ahead and zoom in down at the wrist end of things. Okay. So I want to start with the radius and then compare that to the ulna. Okay, so the important bony landmark on our radius distally, by the way, bony landmark is something that we can palpate. We can put a finger on and touch, right? There are plenty of bones in our body, 206 bones in an adult skeleton. You can't touch every single one of them, every single part of every single one of them, right? Some bones have bony landmarks. They kind of stick out a little bit. We're going to call these down at our wrist a styloid process. So our radius has a styloid process. So does our ulna. Okay, if you look at your wrist, right, you can feel kind of these bumps on the pinky side and the thumb side, right? Where you can feel the bone, you can kind of feel where the bone ends, yeah? You can feel these little bumps. When you feel those bumps, you're pushing right on the styloid process of the radius if you're on the thumb side, and you're pushing on the styloid process of the ulna if you're on the pinky side. Which one sticks out more?
Pinky side.
Yeah, pinky side. When the ulnar styloid process is more like evident, right? Okay, there's nothing deeper there. That's just the truth. The ulnar styloid process is a little more evident. You can feel it more, but they're little wrist bumps. Okay, so now you can safely say that, like, when you feel these, the styloid processes, everything distal to that, right? That's the end of the bone. Yeah. So everything that you feel or see beyond that is all wrist. Now you can quickly and easily tell where the bones of the forearm stop and then where the wrist bones begin. Okay. If you poke a little harder, you can also feel like your metacarpals here, right? You can see where the metacarpals end. You can see where the ulnar styloid process is and radial styloid process, and then between those two things, you've got your carpal bones. Okay, those are harder to feel because they're like embedded in, tendon and ligament and stuff, but they're there. They're all right there in that spot. Okay, styloid processes. That's our first thing. Let's move up a little bit, just the tiny amount, to look at the heads of the bones. Okay. By the way, we have a better term for the head of a bone. What's it called? The ends of long bones. I'll give you a hint. It's got epi in the name. Ooh, that's a good guess, but it's epiphysis. Okay, so let me zoom back out here and let me give better names to these things because these are going to come up. The length of the bone, right? What makes up most of the length of the shaft of the bone, what they're calling the body or the shaft, I'm going to call, and it's more correct to call, the diaphysis or diaphysis. Okay, and that's true, down to about, let me go a little further, down to about there, okay, and up to about there. So you have kind of the shaft of the bone, the length of the bone, body, shaft, or diaphysis, which is the most correct name for it, okay? But then you notice, so the shaft is kind of skinny, right? What do you notice down towards the end of the bone? What begins to happen? It widens, right? It kind of flares out, okay? So that flaring, all of that, right, that kind of shape there, that we're going to label the metaphysis, or metaphysis, so everyone else says it, but metaphysis if you like. Okay, let me erase this. Okay, so you have your diaphysis, metaphysis, and then, if it's a child, there's an open space here, right? And in a child, there's an open space after the metaphysis. We call that the epiphyseal plate, right? In a child, when it's open. Let me give you an example. you'd like to come up and look, you're welcome to. But you'll notice down here at the, this is a lateral elbow, put it the wrong way. But you'll notice it looks like there's a break in the bone here, right? Like a big dark line running right through here, okay? Like, man, that kid broke his elbow, right? No, this is just an open growth plate or epiphyseal plate. This person is a child. This is my cousin. He was, 14 when he did this, okay? And this is after reduction, so you're not going to see any pathology here. He dislocated his elbow. But anyways, you can see this open line right here, this dark line. And then past that is bone, and on the other side of that is bone, okay? That's an epiphyseal plate. Open in children, shows up dark. And that would be, if that's the ulna we're looking at in the elbow up here, down at the wrist, there's also one. So at the end of every long bone, there's this line, this plate, this open area where the bone is growing from. That's how our bones grow in length, okay? They don't grow from the very tip of the bone. They grow from somewhere towards the end, right? Okay, but in an adult, okay, let's look at, so here's a lateral elbow from an adult, okay, compared to the lateral elbow in that child. Open plate, black line here, no black line there, okay? That person's epiphyseal plate has fused. Once it fuses, once this line fuses and becomes a bone, we're just going to call it the epiphyseal line, okay? So I'm going to put a label to that. This is running out of ink or color or whatever. That's just a horrible color. All right, we're going to fix this. Hang on. Let's try this. A little better. So the epiphyseal line right there. Okay. And then you'll notice that there's the line that I drew in blue, but there's still bone past that, right? So this tip or end of the bone, which we have a little labeling like styloid process, which is just that little tip, but this whole thing at the end is going to be called the epiphysis. So you've got diaphysis, body of the bone. Metaphysis, where the bone flares out, okay? Epiphyseal line, if it's an adult, or epiphyseal plate, if it's a child, or growth plate, if you like. And then epiphysis, the tip of the bone. So while I'm probably going to say head and shaft and things like that, right, and growth plate, these are the right names to use, okay? And every long bone has these. Most bones have these characteristics, but every long bone has every one of these characteristics. Diaphysis, metaphysis, epiphyseal line, and epiphysis. Okay, questions here?
So test purposes, like for our board,
Yeah,
we have to know these names instead of,
you should know both.
oh, you should know both.
Both might show up, right?
Yeah.
In different contexts, yeah. You should be prepared for both, though. Yep. These are the right names. These names are, they're just right. These are also right, just at different levels of explanation, different levels of technicalness, right? Okay, good. By the way, if that's true for this end of the bone, it's also true for the other end. Okay, I'm not gonna go and separately label the other end right now, but it's true for both ends of a long bone, right? If this end of a long bone's got a metaphysis, epiphyseal line, and epiphysis, this end does too. And you can kind of see where the radius begins to flare out. You can make out where there should be a little line there, and then you have the tip of the bone. Okay, so even though they look different, the ends of the long bones all have these same things. Every phalanx in your phalange has that, right? It's got a diaphysis, a metaphysis, an epiphyseal line, and an epiphysis. Every little long bone's got one of these. Metacarpals do. All of the long bones have this. Okay, good. With that said, let me move on. And we'll zoom back in. Okay. So the arm's being held out to you like that with the palm up. Again, we like anatomic position for everything, right? So patient's palm is out, facing towards you. Medial lateral, radius, ulna, head of the radius, head of the ulna. You'll notice the head of the radius is large, head of the ulna is small, down at the wrist end of things. When two bones touch, what's created when two bones touch each other? A joint, right? Some joints are freely movable, right? These joints, right? And other joints are immovable, like those in my skull, and some are kind of in between, like the joints in my spine, right? Here's a kind of in between one, okay? It's kind of an in between. It's a little bit movable, okay? This joint has to be able to allow the bones to kind of shift a little bit on each other as we just roll around, okay? This is going to be our distal radio-ulnar joint. And I like when joints are named because often joints are just named for the bones that make them up. There's no complicated name, doctor's name associated with it or anything. It's just here's the joints, here's the joint, here's the bones that made it up. Distal, because it's further away, okay, towards the tip of the extremity of the body. Radius and ulna, radio-ulnar, and it's a joint. Couldn't be more self-explanatory. Okay. On the ulnar side of things, there's a little notch, little depression in the ulna, okay, that the radius just kind of sits in like that, okay. That's the joints created by radius and ulna. The ulna's got a little notch in it for the radius to kind of poke into it. Okay. Again, not a lot of important things happening in the middle. Okay, so we're going to go up to the proximal end now. Proximally, let's focus on the radius first and then the ulna second. You'll notice that the roles kind of switch, right? The radius was big at the wrist, it's now small up at the elbow. The ulna was small at the wrist, it's big at the elbow. Radius here, ulna here. On the radius side of things, bony protrusion called the radial tuberosity can be seen on every radiograph. Proximal to that, we call this the neck of the radius. Okay, so you hear a physician talking about a radial neck fracture. They're talking about a break in the bone that happened above this landmark called the radial tuberosity. And you could guess, anytime there's a protrusion from a bone, right? It's usually because something like a tendon is pulling on that, okay? So these tuberosities are going to be for like tendon attachment things, and we don't go into that, right? It's past what we need to do. But you can bet when there's something sticking out from a bone, it's because it's getting pulled on all the time. Okay, anyways, proximal to the radial tuberosity, we have the radial neck here. The radial head is this rounded thing, which was actually the epiphysis of the bone. And the radial head is one of these really commonly injured parts of the body. And it happens because often people fall, and when they fall down at the wrist, the radius is the largest bone, so it takes all the impact and sends it right up the radius and shoves the head of the radius up into the distal humerus, the elbow. Okay. This radial head is an important structure. We'll need to be able to look at that. We'll also need to learn several different ways of positioning during radiographs to view that bone, right? One of the best ways is to do a full extension AP view like this, okay? Right, palm up, full arm fully extended. But I don't know if anyone's had this experience with patients. Often when people have actual injuries to the elbow, including radial head fractures, they're stuck like this. They just won't or can't go into full extension, okay? So we're gonna have to have several ways of doing, positioning the elbow so that we can get these things. Who's had experience with the elbow? You have. Have you had people stuck in partial flexion?
Yeah, this one girl, she had like a pillow
Yeah.
on her chest and she just had like this.
Now, let me fast forward to the end of the exam. Did she have any fractures, any pathology? Was anything actually wrong? No. Okay. But could not go into full extension for you? What did the X-ray tech, or what did you do in that case?
She angled the ray differently.
So was she able to do the images with the patient partially flexed, right?
So she kind of got her to let go of the pillow and kind of kept it like this.
Gotcha.
And then the ray, I think it came. I forgot how she put
Yeah,
it.
but she has to do things
Yeah.
differently,
Mhm.
right? From the tip, and you've done other elbows besides that,
Yeah.
right? And it's different, right? When the patient's stuck in some partial flexion position, can't move, you have to change what you're doing, you know? So, and I'll teach you ways to do, you know, the elbow should be done in full extension like this, right? That's, well, those are all laterals up there right now. But anyway, I'll get some other ones up in a little bit, but the elbow should be done in full extension, okay? If the patient's stuck in partial flexion, that's not a perfect view of the elbow now, okay? So you have to have ways of doing this. I'll teach you those. There's also ways of imaging the elbow if the patient's stuck in what we call acute flexion. Like after a dislocation or something, they could be stuck like this, okay? And just not have any ability to extend at all. And what in the world do you do when they're stuck like that, right? Can't get them on the table for the lateral, can't get them extended for the AP, so what do you do? And I got ways of doing that. I didn't make them up, the book has them, but I have to be able to teach you them, right? So we'll have ways of doing all these things, but the radial head is going to be one of these things that just, it's an easy to hurt bone. Okay, radial head. Recall down at the wrist, the ulna has a little indentation for the radius to fit in, right? The distal radio-ulnar joint. We have a proximal radio-ulnar joint up here, okay? Proximal radio-ulnar joint. And the same thing is true. The ulna makes some space for the radius. Okay, so there's our radius, important stuff. Tuberosity, neck, and head. Coming over to the ulna now. We talked about the joint just a second ago. Lots of important things happening on the ulna, okay? Let's just label a few of them for now. A tubercle. Tubercles are other names for little protrusions from the bone. We just happen to call this one a tubercle. It's kind of like saying a little tuberosity. So we've got tuberosity here, big protrusion, and then a tubercle, a little protrusion. This and this are easier to see laterally, but we have our coronoid process and our olecranon process. Processes, for reasons I won't go into, are also words to mean little protrusions from a bone, okay? You're gonna hear process, you're gonna hear tuberosity, you're gonna hear things like fossa, right? All these are names for protrusions, indentations, deformities, not deformities, but shapes, morphological differences in shape of the bone. Coronoid process and olecranon process, you're seeing them like that right now, okay? Looking straight on at them, but really they're like a circle, like a half circle, okay? This is a cup, okay? The ulna makes a cup like this, and we're just looking straight on at the cup right now, okay? From the side, you would be able to see that it has a definite kind of U shape to it. All these, I don't know, whitish, super light blue kind of shades here, those are representing articulations, places where the bones are going to rub up against each other. Okay, these are on a person. These are just going to be sort of really smooth areas where the bone can be kind of rough. Everywhere else, where the bones actually rub together, very smooth. All right, so we had 3 things on the proximal radius, 3 things on the proximal ulna, and 1 joint space proximally. Okay, so radial tuberosity, neck and head for the radius. For the ulna, coronoid tubercle, coronoid process, and olecranon process. That's one way to look at things. Okay, a different way to look at things, especially in the elbow, is laterally, looking at it from the side. So right now you're looking at it from the front as if the patient was standing in front of you like this. Okay. But with the elbow, we'll find that most of the time it's easier to view the structures from the side, at least in certain cases. The ulna is one of those cases. So now we took that thing that was facing at you like that, right? And we rotated it. Now you're looking at it from the side, okay? So this is our proximal. Nothing interesting happens to the radius when you look at it from the side. It's just like a circle, right? You take a circle and turn it, it's still a circle. But the ulna is interesting from the side, okay? From the side, you can see, as kind of my hand is making the shape here, that it has this indentation, okay? We call this indentation the trochlear notch, okay? Trochlear notch is the name for the indentation. This now gives us something to wrap around the humerus, which is going to be, of course, attaching the upper arm's going to come in here, right? This is going to wrap around the humerus and give this kind of articulation like this. This hinge type joint, okay? Hinges like on a door, right? Hinges only go one way or the other, right? So I can't swing that door any old direction. I can close it or I can open it. The elbow's the same way. I can extend the elbow, or I can flex the elbow. Trochlear notch. Now you can better see the olecranon process. The olecranon process is just all of this, okay? So what you can touch here, what you call, if I asked you before the lecture, before ever taking this course, point at your elbow. If you ask a 6-year-old, point at your elbow, they're going to point right there, right? What they're really touching is their olecranon, okay? When you whack your elbow down on something, you're striking your olecranon, right? Blunt trauma to the olecranon. That's what sticks out from your elbow. In the front or anterior of the ulna, from the side here, the coronoid process. So the coronoid process kind of makes the front lip, right? And the olecranon kind of makes the posterior lip to this cup thing making the hinge. Okay. So that's as viewed from the side. We'll go back to the side view in just a moment here. I want to now talk about the distal humerus. Okay, so distal humerus. Distal humerus is going to have articulations, smooth spots on it, so that the radius and ulna can butt up against it and move against it. Okay, so here we go. Let's start, in this case, let's start proximal and work distally towards the elbow. Okay, and we talked about, we're going to be doing most of this about the lecture's forearm and elbow. Most of this is going to be talking about the elbow because there's more happening here. Okay, but anyways, our elbow joint made by the distal humerus, proximal, radius, and ulna. Let's start proximally on the humerus and let's work downward. So again, the bone is called the humerus. Okay, the diaphysis of the bone, the shaft of the bone comes down, begins to flare out. You guys know by now that's called the metaphysis or metaphysis. Okay. And the epiphysis of the humerus is all this down here, okay? So when viewed like this from the front, anteriorly, you'll first notice on either side of the humerus are little pokey things, okay? Those little pokey things happen to be called condyles, okay? Condyles or epicondyles. So you have a medial epicondyle and a lateral epicondyle. If you kind of feel, you can feel these on either side of your elbow. The medial one's easier to feel than the lateral one, okay? But these kind of stick out. And you'll notice like the medial one's just bigger, right? This one labeled medial is bigger, lateral is smaller. But these are little protrusions. You can feel these little protrusions in your elbow. Okay. 2 depressions in the bone, the coronoid fossa and the radial fossa. And let me come over to the skeleton for this. Actually, what is this? So, same bone, same side like this. These 2 little depressions here, depressions are called a fossa, okay? Here and here, coronoid and radial fossa. These are there so that when we bend our elbow, when we close this joint like this, the coronoid and the radial head have somewhere to go. Okay, if you want to flex as far as you can, right, the coronoid's going to run into the humerus. Okay, this little protruding tip needs to have somewhere to fit. Okay, so we have a fossa. You'll also see this on the posterior of the elbow too. Okay, there's an olecranon fossa that when we fully extend our elbow, the olecranon back here, right, this part of the cup, tucks into, right into that little depression in the bone. So posteriorly, which we're not looking at right now, there's a fossa for the olecranon. Anteriorly, there's a fossa for the coronoid process here to fit in, and the radial head to also fit in. Okay. Now for our articulations, okay? We said the ulna down here had a notch in it, and we labeled that notch the trochlear notch, right? So the distal humerus that fits into that part of the ulna, well, we're going to call that the trochlea, okay? Trochlea is the articulation for the ulna. Ulna fits right in there. This one, so there's a ridge here. Lateral to that ridge is a smooth, rounded end of the humerus that the radial head down here, right? Humerus here. The radial head kind of just rubs on it. Okay, it doesn't cup around it like the ulna does. It kind of just flat. It kind of rubs on the end of this. Okay, so the radial head, as we flex our elbow, as we bend our elbow back and forth, just rubs up and around that thing, this articulation here, called the capitulum. Okay, it comes from the word capitulate, which means to like roll over, right? And that's what the radius does, right? If you think about what your elbow does, you can have two basic movements, right? You can have the flexion extension movement. I'm counting that as one movement, right? Flexion extension. That's all done by your ulna, right? Your ulna gives you the extension, flexion. But if you want to put your palm down, right? You want to take and you want to, we're supinated right now. If I want to turn my palm down, okay, watch what has to happen to the radius. The bones are uncrossed right now. They're separated. I can see a line going right through them. You know, I see a space between them, right? And when I want to turn my palm down, watch up here what the radius has to do. The radius has to roll, okay? It has to roll, and there's a lot of space right here, but there's not typically that much space. It has to roll, and it has to roll against something. It has to roll against this, okay? It has to roll against the capitulum. And it has to be able to do it, right? Because you can twist like this at the same time as you're doing flexion, right? I can do these movements at the same time, right? That means the radius has to be able to roll at the same time as I'm flexing. I can go into full flexion and roll, pronate, supinate. I can do that in full flexion. I can also do it in full extension. I got a little bit more movement in full extension, right? But the radius, the radial head has to be able to roll around through the full swing, through this full extension flexion swing, right? The whole time, at any point, I have to be able to roll this radius. The capitulum is this smooth, rounded end of the humerus that allows for that. Okay. Capitulum, from the word capitulate, there's a root word in there, meaning to turn over or roll. Okay, so I think we did it, right? Body or shaft or diaphysis, condyles or epicondyles, coronoid, radial fossa, trochlea, capitulum, and then we already talked about the bony anatomy of the radius ulna. All right, interesting stuff happening from the anterior perspective, right? Looking from the front. Lots of interesting things happening from the lateral view as well. Some similar, same anatomy, but let's take a walk through this. So now you're seeing this the same as these, or at least close to the same as these, okay? This is a true lateral view. In the true lateral view, you can see, or you should see, a defined space between the trochlear notch and the trochlea itself, okay? The first thing I will want you to try to get used to seeing radiographically are three concentric rings. Concentric just means the kind of one inside of the other, okay? So there's the ring of the trochlear notch. I forgot this one's dying. There's the ring of the trochlear notch here, okay? There's the ridge of the trochlea, and then there's the ridge of the capitulum here. Three, they're not full circles, right? We're going to call them rings when they're like open, but three concentric rings or arcs. If the person is positioned in the true lateral where, and of course we're looking at it from the side right now, if they're positioned in the true lateral where their humerus and forearm are both parallel to the tabletop, okay? we'll see this, okay? Pending you're doing all the other positioning things that I'm not saying, but I am showing, pending you're doing all of those correctly too. However, what happens often, see how low I have to get to make that happen, right? Typically patients are seated in a chair, okay? So what often happens is, because they're seated in a chair, my forearm and radius ulnar parallel flat to the tabletop, but you'll notice when I set up a little bit, my humerus now makes an angle to the table, okay? So you're not going to see a true side view, a true lateral of my elbow in this case, okay? And the further up I come, the worse it gets, okay? So when we do any extremity position, we want to make sure all bones associated with that anatomy to be demonstrated are parallel to the image receptor or tabletop, okay? Okay, that makes sense? Okay, good. So, you get somebody seated in a chair, lateral elbow, they're up like this, right? What do you have them do? What are you going to tell somebody to do when they're up like this, they're not down? I can raise the table maybe, right? Does everyone have a raisable table? No, not everyone, right? But lots of us do, right? So, but if I don't, I lower the chair, yeah? Let's say the chair's as low as it can go. What else can I do? I can raise the image receptor, right? Now, I don't want to use like pillows or anything wonky to raise the image receptor. I want to maybe sponges, our radiographic sponges, right? Use those. Those are pretty stable. That's a really good idea. But then, so let me give you a one but then kind of statement. But then I am now bringing the image receptor closer to the X-ray tube, right? And we have a source to image distance we're trying to maintain, right? So what's that distance, by the way? 40 inches, right? 100 centimeters. So I can raise my X-ray tube up, yeah? However much I raise the image receptor, let's lift the X-ray tube up that much. But even easier than all of those things, just have the patient hunch down, right? Any of those things that you said are useful and they will work, but you can also have the patient just hunch down a little bit, like a tiny bit, not the tiny bit of an awkward position for a moment. As long as they're stable enough to stay in that position, you're going to be just fine. Okay. All right, so there's the three arcs. I'm going to come off of this picture for a second here to show you those radiographically. So there's what we're looking for. Trochlear notch, trochlea, and capitulum. They're labeling trochlear sulcus too, but I really want you to focus on trochlear notch, trochlea, and capitular ridge. This trochlear sulcus here and capitular ridge are often overlapping each other. You can see what I'm trying to show you, hopefully, radiographically. So, trochlear notch, okay, trochlea, and capitular ridge here, okay, all three concentric rings. Now, as the arm gets raised, the shoulder's up there, right? So as the arm gets raised off the table, our whole, reference, our view rotates. What we see will be rotated or distorted from what it actually should look like in those cases, which is why we want to make sure our patients are as flat to the table as they can be. Okay, so that was our three concentric arcs or rings, if you like. Okay, let's take a look anterior on the humerus and then posterior. Anteriorly on the humerus, just take note that there was those fossae, right? Those depressions in the bone, coronoid and radial fossae, fossa for one of them, fossae, AE for plural, not fossas. Then we have the ridges, capitulum and trochlea. Coronoid process is easy to see laterally. So if a physician suspects a coronoid process fracture and says, hey, do you have any images that demonstrate coronoid process fractures? You know the lateral does that, and by the way, they will too, right? But I'm just giving you, they may not, right? But they want to see the coronoid process. There it is. It's there laterally, okay? We want to see the olecranon process. There it is. So our lateral gives us olecranon process, coronoid process, easy to hurt things, okay? You fall onto your elbow like that, your olecranon gets injured, you fall into your outstretched hand, the whole thing gets shoved up this way, coronoid process and radial head are at risk of impacting into the humerus. Trauma happens to those, okay? So we want to have ways to see those things, okay? Ways to see the radial head, right? The radial head is here in this view. We're basically getting a side view, not basically, we are getting a side view or lateral of the radial head. We're getting a side view of the radius and ulna, as well as the humerus. That's what the lateral is good for, okay? All right, so fossae, olecranon, coronoid, radial head, and that's most of what's important here. Good. I also want you to take note here that the epiphysis of the humerus is not in line. Like if I draw a line down the center of the humerus, right? That is not cut through the middle of the epiphysis. The epiphysis is angled forward. Okay, this end, let me erase all this. This end of the humerus is not sitting in a straight line with the humerus. It's angled forward. Okay, this becomes important in small children when we worry about what are called supracondylar fractures. Supra means above. Condylar refers to the condyles, this end of the humerus, what I was calling like the epiphysis, right? In small children, again, the most common way to get hurt when you're cruising around is to fall, right? And you fall, and what do you instinctively do when you fall? Put your arms out, right? So it's so common that we have an acronym for it. I may have even said it and forgot already today. We have an acronym for falling, okay? We put our hands out. Anybody know it? Anybody know the acronym? Fall onto outstretched hand, or FOOSH, okay? Doctors talk about FOOSH injuries all the time, okay? F-O-O-S-H, fall onto outstretched hand. That means you fell and you went, ah, you stuck your hands out, right? Because it's just sort of instinctively. Nobody falls and, you know, face dives into the ground, right? We all put our hands out. So that's such a common thing, there's an acronym for it. Now in grown-ups, right, in ossified skeletons, coronoid process, radial head are big subjects for trauma. Down at the wrist gets a lot of injuries, right? You know, fractured, radial fractures, things like that. But in children, if they're not breaking things down there, okay, nothing might be wrong too, but if they're gonna fracture something and it doesn't happen down at the wrist end of things, we look up to the elbow, okay? And in the elbow, the humerus is subject to fracture because all these forces coming, you know, this direction, right, are going to push on the distal humerus. And what can happen is it can take this whole condyle, this whole end of the humerus, and rotate it backward. Okay? So what physicians will often do is they'll draw an imaginary line or an actual line down on the anterior of the humerus, the anterior humeral line, just extend it down, and it should pass right through the middle of that circle. Okay? Right through the middle. Okay? In the case of supracondylar fractures, everything gets rotated backward. Okay? And you won't see a break. You don't see a break in the bone like you see with grown-up skeletons, right? You will see just everything shifted backward, and they draw this anterior humeral line, and all of a sudden everything is behind that. Okay, all of this gets rotated or shifted or bent backward, if you like. And that's what we call a supracondylar fracture. Supra means above the condyle, so the fracture's happening up here or higher. Okay. Okay. Let's see how you guys did. So I'd like you to, with a piece of scratch paper, try to put away your notes. I want to see how much you can do just from what we talked about. Okay, so I'm going to pause the recording here.